Assalamu alaikum. Today I will speak about how to take history in basis. History is in station 2, about 20 marks in the exam. To take history in a proper way, you have to put in your mind how to reach the diagnosis and how to make a communication with patient. In history, you can face a lot of medical problem. You can be, could be cases present with symptoms or many symptoms, and in other way the diagnosis of patient uh, was clear, like patient present with diabetes or rheumatoid arthritis, and the patient complains from symptoms related to the disease like diabetes, and he presented with uncontrolled diabetes mellitus, or rheumatoid arthritis and the patient presented with joint pain. Other way, the patient could be presented with lab result and unrelated symptoms like fatigue or shortness of breath. And put in your mind, many of cases in the exam, the diagnosis that given to you is not the actual diagnosis. Could be the patient presented with uh, bronchial asthma, presented with shortness of breath, and he was diagnosed before as bronchial asthma patient. You have to first should be sure this patient has bronchial asthma or no. Most of patient, it could be something other bronchial asthma like pulmonary hypertension, pulmonary embolism, recurrent shower, or this patient has occupational asthma and he doesn't relieve with nebulizations or inhaler. In history, you have to make a plan for yourself. You make this plan many months before the exam, and you have to do this plan in every day, and you have to do the history in the same way in every day until the exam day. Some people expect the history case is easy, and they are reluctant to study history, so that history is uh, uneasy, but you have to do a lot to take full mark in history. Actually, if you follow this instruction, you will get the full mark without without loss any marks. You have to do first, you have to do daily history with your colleague or with yourself, with loud voice, with in your daily clinic, by the same way in basis exam. To be fluent, to be minded by the questions and what is the way of ask of this question, as you may be lost to ask about one simple questions like family history or period in female. If you forget to ask about something like that, maybe you will lose the diagnosis. I will give example about that. One patient presented with an anxiety disorder and anxious, and she feel sweaty, and she has feverish fever. She described fever and fire in her body. All of Candid think in pheochromocytoma because the patient presents with attack of sweating, anxiety, and mild hypertension. But some candid lost to ask about period, and this patient was young, about 30, 39, and she didn't have period now for 3 years because there's an operation done for her due to vaginal bleeding, and there's hysterectomy, so that the diagnosis is clear now. It is menopausal symptoms. We have to put in our mind the pheochromocytoma, but the first differential diagnosis is menopausal symptoms. And all of Candid at this time doesn't mention menopausal symptoms for the examiner. So that you have to be asked about every point I will tell you about it now, even to be a routine, and make it a routine questions. Maybe you put in your mind, it could be unrelated to the diagnosis, but if it is positive, you can reach the diagnosis easy. Like patient, maybe this patient has weight loss. You have to ask about travel history. For the first time, what is the relation between travel and weight loss? Yes, it could be there's a relation, like HIV. It could be related to weight loss. It could be there is a relation, chronic infections, tuberculosis. So that you have to ask about every system, even if you think it is unrelated to the diagnosis. For history, we can divide the history for three main parts. Number one is an introduction. Number two, the main target of history. Number three, end of discussion. Number one, introduction. As in a meeting, you have to introduce yourself. After that, identify the patient. After that, ask permission from the patient to discuss the issue that mentioned in the referral from GP. The three most important things. You have to tell the patient like, good morning, my name is Dr. Ahmed. I am senior house officer of medical department, and give time to the patient to reply. Yeah, don't speak quickly. You have to stop after every sentence to to give the patient time to reply you. Then tell him, today I receive a letter from your GP. Your GP mentioned for me you are complaining from shortness of breath and chest pain for 3 months. It is all right for you to discuss this issue today. We take here a consent, it is verbal consent from the patient to discuss something related to his medical problem. In the introduction, try to write the name of patient in blank paper with you. Why? You have to tell the patient to speak with the patient by his name, because maybe you forget the patient name. This may give a negative impression about you for the examiner. After that, you have a complaint. This patient has complaint. First, you have to analyze this complaint by ask about the onset, course, duration, what increase, what decrease, if the patient receive any medication, if the symptoms are current for patient. After analyze this symptoms or the complaint of patient, you have to look for other symptoms related to the complaint. I mean, if the complaint related to chest problem, or if the complaint related to abdominal problem, you have to ask about other symptoms related to the pain, related to the main complaint. If the patient has shortness of breath, after you analyze the shortness of breath, you have to ask about the symptoms of cardiac and chest. You have to ask about chest pain, awareness of heartbeat, racing of the heart, cough, hemoptysis, leg swelling, change in the voice of patient. Number one, analyze the complaint. Number two, ask about other symptoms related to the system that the patient have been complained from it. Number three, you have to put differential diagnosis. that is already outside the exam room, you have to put differential diagnosis. After you analyze the complaint, you have to ask about the differential diagnosis one by one. I mean, if you have patient with shortness of breath, after analyzing complaint, then review of other symptoms related to chest and cardiac symptoms. Number three, you have to put differential diagnosis. If you suspect this patient could be pulmonary embolism, you have to ask about the precipitating factor of pulmonary embolism in 1 to 2 sentences. You have to ask patient about past history of blood clot, family history of blood clot, long travel, bedridden, any medication, like that. Maybe you suspected to put the past history of blood clot to ask it about to ask the patient about it in past history. No, it is not expected to do that. You have to ask about everything related to your differential diagnosis in present illness. Don't put in your mind to postpone that to past history or family history or travel history, because now you want to give the examiner impression you are searching about the pulmonary embolism. Maybe when you reach the past history, you maybe forget to ask about blood clot, because you will be like checklist for you. You will ask past history, family history, drug history, and social history, so that you have to ask about any symptoms or any precipitating factor or risk factor about your differential diagnosis in one manner or in arranged manner. Then start to ask about other differential diagnosis. If you think it could be interstitial lung disease, you have to ask about cough, type of cough you asked, and skin eruption, joint pain, like that, in 1 to 2 sentences. If you suspect it could be bronchial asthma, you have to ask about precipitating factor of bronchial asthma, like, do you have bees in your house? Do you exposure to dust? Do you live in revolution area? Do you have a history of allergy or history of eczema? So that you give the examiner a lesson. You are speaking now about bronchial asthma, so that he put in his mind you are speaking about the asthma, and he will write in his note your history is structure and your history is to the target. After you finish your differential diagnosis and asked about everything, the third thing, you have to do review of other systems. Most of candidates forget to ask about review of other systems. Review of other system is very, very important, because maybe you catch one symptoms of the patient, so that the patient could have systemic illness. And this patient, you suspected this patient has bronchial asthma. If you asked more about that, this patient could has diarrhea. It could be he has flushing of the skin, so that you will put in your mind these patients could have carcinoid syndrome. So, very, very important to search about review of other system. Review of other system, we have about, I think, 12 system. This one, number one, general. Number two, GIT. Number three, genitourinary. Number four, chest. Number five, cardiac. Number six, central nervous system. After that, blood problem, skin problem, joint problem or locomotor system, gland problem like thyroid, this 10. There is more too. It is very important to ask about the two remaining, like psychiatric history. It is very, very important to ask a patient about psychiatric history. Very important, if you are speaking with female, you have to ask her about period and oral contraceptive pills and pregnancy. That is very important. Again, if you are discussing with female, you have to ask her about period, oral contraceptive pills, and pregnancy. If the patient complains from pain in any side of his body, like chest wall pain, or joint pain, or backache, you have to ask him about trauma. Now I will go to again for review of other system. It is very important review of other system to put in your mind. Now I will tell you how to keep that in your mind. You have 3G. Number one, general. Number two, genitourinary. Number three, GIT. You have 3C. C num central nervous system, cardiovascular disease, and chest symptoms. Then you have H, hematology, L, locomotor, G, gland, and C, S, scan. Then to B, period with psychiatric history, trauma, if the patient has pain. General symptoms. What is the general symptoms? You will ask this patient with non-medical terms, like what? Do you have fever or raised body temperature? Do you feel fatigue? Do you have sweating, especially sweating in the night? Do you have lumps or bumps in your body? This means lymph node. Does the symptoms affect your sleep? Then you will go to, we will ask about GIT. GIT, nausea. We can ask the patient, do you feeling sick? Feeling sick means nausea. Do you becoming sick? Becoming sick means vomiting. Do you feel heartburn? Difficulty in swallow? Abdominal discomfort? Tummy pain? Pain on both sides of the back? It means loin pain. It means loin pain. Pain on both sides of the back. Do you have any change in your bowel habit? Don't tell the patient diarrhea or constipation. Tell him, do you have any change in bowel habit? If the patient tells you yes, ask him, do you feel your bowel habit loose or hard? If there is loose, if there is diarrhea, you should have to ask about odor. طبعا yes, you have to ask about onset and the course and duration, what increase, what decrease. It is related to food. It is related to any type of food, or it's to any type of fluid. Then, but you have to ask about odor. You have to ask about frequency, how many times per day. Do you have to ask about flushable or not flushable? I mean, if you or flushable or not flushable, and if it is the stool folate in the pan, and folate of the stool in the water, that means steatorrhea. All of these you have to ask about it in diarrhea. Constipation, you ask the patient, do you have hard stool? How many times do he pass stool by the week? And what's about the previous bowel habit? Also, you have to ask about pallor and jaundice. Most of candidates forget to ask about pallor and jaundice. Very, very important if the patient has fatigue or abdominal problem to ask about pallor and jaundice. Pallor, you have to ask the patient, does anyone informed you your skin of your face become pale than before? Very, very important, because mostly in the exam the patient complain from fatigue. Could be anemia simply. could be has pallor and uh, lymph node. Jaundice, you have to ask the patient, do you notice in or anyone notice your eye white changed? The color of your eye white changed or no? This is pallor and jaundice. Then ask about change in the water work. Change in the water work, very, very important. Water work means urine. Don't tell the patient urine because it is medical term. You have to tell him water work. If the patient has polyuria and he told you increase, he went to, he is going to the W bathroom many times, you have to ask him about urine, about the water work amount. Tell him, if you went to the bathroom, do you pass a lot amount of fluid or no? Because it could be he went to the bathroom frequently, but it's a little amount, not huge amount. Ask about the if he has any problem in the water work. Ask about amount, color, any pain, any any pain. If he told you there is a change in the color of the urine, become dark than before, please don't forget to ask about the time. Again, put in your mind most common case of history in the exam. If the patient has black stool or sorry, dark stool, you have to ask him, is it present all time of the day or at one time or it is morning or evening? Why this question? Because paroxysmal nocturnal hematuria, could be present by that in the morning time with dark urine. Water work was finished. Then you will go to CNS. CNS ask about, do you feel the room round, this dizziness? Do you feel any abnormal movement? Do you have any abnormal movement? Do you have weakness? Do you have any change in to control your water work or back passage? Any pins and needles in your hands, like peripheral neuropathy? Any change in your eyesight? I mean, there is vision changes. And if you have any symptoms positive, you have to analyze the symptoms. After the CNS, there is chest. Chest, you have to ask about cough, shortness of breath, leg swelling, chest pain, but the very important change in the voice. I am telling you it is very important because most of us forget to ask about it. Why? It could be this patient has shortness of breath and cough. It could be malignant, so that infiltration of recurrent laryngeal nerve could be lead change in the voice. Also, you have to ask about awareness of heartbeat and racing of the heart. There is a difference between awareness of heartbeat. Awareness of heartbeat means palpitation. Racing of the heart means tachycardia. And if you found the patient has awareness of heartbeat or tachycardia, that means racing of the heart, you have to ask him about the rhythm. You have to tell him it is regular like that and knock by your hand in the desk, or irregular like that. You have to do that for the patient to know it is irregular or regular. You have to ask about blackout. What does mean by blackout? Blackout means syncope. You have to tell him blackout. Don't tell him syncopal attack. You have to ask him if he have dyspnea. If he has dyspnea, you ask him about paroxysmal nocturnal dyspnea and snoring during the night. Why snoring during the night? One case in the exam, the patient presented with fatigue and he has hypertension. And a lot of investigation were done for him. It was normal. After the candid analysis, everything for this patient, he couldn't find what is the cause. He couldn't. Fatigue and hypertension. One person told it could be chronic kidney disease. Yes, I am with him. It could be chronic kidney disease. But if you do for this patient and concentrate in his history and the concern, because the concern of this patient presented with fatigue and hypertension, he has erectile dysfunctions. He is receiving he's I think he received ACE inhibitor. He didn't receive beta blocker at all. If you put in these symptoms, hypertension, fatigue, shorts of sorry, hypertension, fatigue, erectile dysfunction, how can these symptoms collect together? If your mind opened and you asked about snoring during the night, this patient has snoring during the night, and he has hypertension, and he has fatigue, so that you have to ask him about about his sleep. If you asked him in the general review of other system about does the symptoms affect sleep, he will tell you yes. I feel many times I sleep during daily work. I have accident before because I slept during the drive. So that the diagnosis now clear. That is called obstructive sleep syndrome, obstructive sleep apnea. So that every point in the history is very important. Don't put in your mind to ask about sleep, it's not important. To ask about snoring during the night is not important. To ask about any point has significant for you, could be positive, could be negative. After chest, we will review hematological problem. You have to ask the patient if he has any bleeding from inside or not. Even if the complaint not related to blood, please ask him about that. You will not. It is 1 to 2 seconds. You ask the patient. If it was negative, okay, but it could be positive and could be related to your the patient complaint. After that, you have to ask about locomotor system. Locomotor means a joint. If the patient has joint pain, you have to analyze the pain and analyze the score of pain. You have to tell the patient if we grading this pain, 0 it is the minimal and 10 it is the maximum. What is the pain score? Very important to ask the patient about pain score. And also what increase, what decrease, onset, course, duration. Joint pain, very important to ask about stiffness. If you have joint pain, you have to ask about 7 questions. Please, don't forget these 7 questions at all. If any patient has joint pain, you have to ask him about. It is not analysis of the pain or morning stiffness. No, I'm not mean that. You have to ask him about if there is any eye problem, any falling of the hair, any skin eruption increased by exposure to sun. I mean photosensitivity. Don't tell him photosensitivity. Tell him any skin eruption increased by exposure to sun. Any muscle weakness, especially proximal muscle weakness. Don't tell him proximal because it's proximal, it is medical term. Tell him weakness in your muscle of the shoulder or weakness of your muscle of the legs, or you during standing from sitting position or combing hair, there is weakness of muscle. Ask him about Raynaud's phenomena. Please, Raynaud's phenomena. Very important to ask patient with joint pain about Raynaud's phenomena. Ask him, do you feel any change in the color of your fingers? Then ask the patient about, we ask about hair, eye problem, skin problem, joint muscle weakness, Raynaud's phenomena, Already we are 7-1 because could be this patient present in station 5. Ask about gastrointestinal change. After joint, ask about the gland. Ask the patient if he has any of swelling in front of his neck or under armpit. But we have now 6 major, then hematology, skin, locomotor, and hematology, skin, locomotor, and the gland. Then ask about psychiatric history. Psychiatric history, you have to ask the patient if do you have any change in your mood. He will ask you, he will tell you yes or no. If no, خلاص, it is finished. If yes, you have to analyze that change in mood because this patient it could be high risk for suicidal attempts. If he told you yes, I have a change in mood, but in your mind you have to ask him, do you feel your life is black? Do you want to terminate your life? Do you want to sit alone? Do you want to cry? If all of three from these 4 questions positive, this patient has highly attempts of suicide. Also, psychiatric history very important, not related because some disease not related to psychiatrist, it could be present with psychiatric manifestation. Some patient like hypercalcemia could be present with depression. Cushing could be present with depression. Acute intermittent porphyria could be presented with depression. And I told you before, many cancers, acute intermittent porphyria patient presented with abdominal pain or recurrent abdominal pain. If you didn't ask about psychiatric manifestation, you will not get it. Then, and you have to put this in your mind and in front of your eyes always. If you are discussing with female, you have to ask about period, pregnancy, oral contraceptive pills, by name, oral contraceptive pills. Don't rely, you ask the patient about any drugs. Oral contraceptive pills in overseas doesn't mean drugs. You have to ask about the period. Don't tell the patient what's about your period only. If you ask her what's about your period only, she will tell you it is okay. You have to ask about 2 questions in period. You have to ask about volume of period and the frequency of period. Because the patient could be, it is high volume and it's huge amount of blood, but it is regular. It could be irregular and normal value. So if you will ask about period, you have to ask about 2 things, volume and frequency, regular or what's about amount of blood. Amount of blood you will ask her about how many times she changed pads and it is different than before or no. And regular or irregular, you can tell her the period is it irregular or not irregular. You have to ask about pregnancy and last pregnancy if she is married or she has a partner. Then you have to ask about trauma. Again, there is a lot of things you can miss during history. Trauma in any pain, you have to ask about, even chest pain, because this patient could be pneumothorax, could be lung contusion from the pain. Psychiatric history, very important. Period, oral contraceptive pills, pregnancy, very important. After you finish, now we are finishing now, present illness, analysis of present illness, analysis of the system related to present illness, then review of other system. We talked about general, GIT, and genitourinary, that is 3G. Then cardiovascular, chest, CNS, another 3C. Then hematology, locomotor, skin, gland. Then female, ask about period, oral contraceptive pills, pregnancy, psychiatric history, and trauma if you have pain, if the patient has pain. Then ask about the past history. Very important to ask about past history, about medical problem, about surgery, about allergy, about blood transfusion. Four important things: medical problem, surgical problem, blood transfusion, allergy. Blood transfusion very important because if you could be this patient has something related to blood transfusion before 99, before 99, for because blood uh, there is no screening for hepatitis C before that. Then you ask about family history. You have to ask like that: family history of same medical problem, family history of something could be you put it in your differential diagnosis. If you think this patient could pulmonary embolism, خلاص, you already asked it there up in the present illness about family history. Don't repeat it any questions again. If you asked some questions before, don't repeat it for patient. Then ask about social history. Social history, before you start to ask about social history, you have to take permission from the patient. Like that, tell the patient, I am going now to ask you about some personal questions, if you don't mind, and stop to ask to take permission from the patient. Or tell him, could I ask you about some personal question? Or may I ask you about some personal question? You have to take permission from the patient because you will breach his confidentiality and privacy. So that you have to take permission, verbal permission. Social history, you have to ask about alcohol, smoking, recreational drug, marital status, with whom he lives, or what is the effect of these symptoms in his life, in his work, and in his daily activity. Then ask about his job, ask about travel history, ask about diet history, ask about vaccination. Again, I will repeat it: social history, alcohol. If you told the patient, do you drink alcohol? Or have you ever drunk alcohol? Why are you asking about that? The patient could be tell you it is occasionally only. Occasionally means low amount. Please ask him about what about how many units. Why? Because the patient, it could be put in his mind that this amount is low, but it could be high for you. So that you ask about how many units. The patient will tell you, it is doctor, it is about 1 to 2 units per day. That is mean 14 units per week. That is okay because we all of us know that more than 21 unit of alcohol is high risk. The patient is receiving now 2 units per day. 2 multiply 7 to become 14. That is okay. Please don't rely on that. Ask him another question. Do you drink on the weekend? Because could be the patient drink more in the weekend. And he will tell you, yes, doctor, I drink about 3 on Saturday and about 4 to 5 on Sunday. Yes, now it is means this patient take high alcohol amount. But again, if you the patient drinking alcohol, please ask him how many units per day and what about weekend. If he drinking more than 21 for male and 14 units for female, you have to ask him about CAG score. CAG score, you have to ask him, do you ever think to cut alcohol drink? Is there anyone annoyed you about that alcohol intake? Do you feel guilty? Number 4, do you open, do you drink during your eyes? Again, do you drink after you opening of the eye? or you drink more in the morning. You have to ask about smoking, how many cigarettes per day, for how long. Recreational drugs, that is mean like cocaine and sharing needle, very important. You could be this patient, you think about any disease transmitted by sharing needle. Very important about sharing needle. Why? I will tell you one of the case. Patient presents with fever and shortness of breath, and this patient doesn't respond to medication in the form of antibiotic, and he is getting worse. If you ask this patient about recreational drug and he told you, yes, doctor, I am sharing needle with others, what do you think? Could be infective endocarditis, right side infective endocarditis. The clue in this case was sharing needle. So that you have to ask the patient. Could be negative, okay, no problem. Could be in your mind, it is not related, but it could be related. After that, you ask about the patient marital status. He has partner or no. Very important to ask about that. Very important. HIV is very, very important in the history case. If he has partner, his wife, okay. If he has extramarital relationship, uh, you can ask him if he is not married. Don't tell him, do you have extramarital relation? Do you have any other partner? Ask him about intimate relationship. Intimate relationship means sexual intercourse. So that you have to tell him, do you do safe intimate relationship? That means he use barrier to avoid sexual transmitted disease. Safe intimate relationship. Don't tell him sexual intercourse. See, intimate relationship. Sometimes people live in England or UK tell that making love, but I think it is intimate relationship. It is a polite term. After that, if he told you he has extramarital relationship or he has partner and he do that without, you have to ask him about safe and intimate relationship because it could be HIV. Then ask about the effect of this disease on his work and his daily activity. Travel history very important because this patient could be has infection. One patient presented with fever before in the exam and he just returned back from Kenya and the diagnosis was malaria. You have to ask him about exposure to people has fever in during the travel and the relation of the fever to travel. It is present before travel or during the travel or after return back from the travel. You have to ask him about vaccination and chemoprophylaxis before travel. Diet history very important in diarrhea, diabetes, in malabsorption syndrome. Now you finished social history. Then you have to tell the patient, I am going to summarize for you the most positive data in your history. If you want to ask me about anything, or if you feel you have something I didn't mention it for you, you can tell me about it. Then summarize the positive data only. Don't tell the patient everything again because no time. You have to tell him like that. You are complaining from shorts of breath, and this shorts of breath increase by daily activity. You have chest pain, and you have family history of blood clot. That is the summary. Don't tell the patient details. After you summarize the patient, you have to end the discussion. End the discussion by very important question. Don't miss this one. Please put this one in front of your eyes and make highlight. It is you have to ask the patient about what is about your concern. You have to ask him what do you have any concern? Very important because concern in the exam in this case only 4 marks. If you fail to get this 4 marks or you get below 2, I'm going to tell you sorry because you will fail to pass the exam. Concern very important. You have to ask the patient what's about your concern. And when you ask about the patient concern, you have to answer the concern immediately. Don't tell yourself I will postpone to answer the concern. Please, if you postpone it, you will forget to answer it. Again, ask about concern and answer the concern of the patient. After you answer the concern, you will start to communicate with the patient. You will give the patient the plan of management in short message. Don't inform the patient the details because you will transfer the case from history to communication. No, just short message. The first one, you have to tell the patient, I will admit you or no, I will not admit. The first term. You have to tell this patient, yes, I am going to admit you now to the hospital. You have to tell him like that. I will request some investigation for you, and I will see you after a couple of days in outpatient clinic if you will not admit him. Then give the plan of care for patient in short term. I will request for you now some investigation. This investigation in the form of blood test that will help us to know the cause of your condition. And will request also imaging in the form of image of the chest, that is mean X-ray, and imaging of the abdomen, that is mean ultrasound, or tracing of your heart, that means ECG. After that, you give patient plan, give the patient differential diagnosis. Don't give him one diagnosis because you only take history. You didn't examine the patient. You didn't see the investigation. How come you will give him one diagnosis? You have to tell him we are concerned about some diseases and we will confirm the diagnosis by investigation and after I examine you. Some patient or some the history cases, the diagnosis it could be clear or you can get the diagnosis from history, but also don't mention it for the patient. But you tell him like that. From our discussion and from this symptoms that I got it from you, I can tell you that we are concerned about the diagnosis. It could be blood clot in the lung, but we are not sure about that now. We are going to do urgent investigation on the form of imaging in your chest with dye. That will confirm the diagnosis. Like that. That's clear. Don't give him one diagnosis. Don't tell him the only diagnosis is pulmonary embolism. After that, finish discussion and tell patient, thank you. And you have to shake hand of the patient, please. Shake hand of the patient. Already in Egypt or in other area like Dubai, if you are taking history from female, not allowed to shake with her hands. But in the UK, no problem. You can shake hand. Then there is 1 minute for reflection. 1 minute the examiner, after 14 minutes, after 12 minutes, the examiner will announce you have 2 minutes only. After 14 minutes, the examiner will tell you finished. Then you have 2 minutes to arrange your differential diagnosis. In this minute, the most critical point, you have finished the history and you are preparing yourself for questions. In this minute, put in your mind the positive data only. This patient has abdominal pain. This patient has constipation. This patient has skin itching of the skin. And this patient has also increased frequency of urine. This is positive data. How to collect the positive data and put it in one sentence. Then put your final differential diagnosis. already before you enter the exam room, you put it differential diagnosis from outside. Now you make reschedule and rearrangement of your differential diagnosis. That it could be hypercalcemia, yes. Then you thinking in hypercalcemia. What is the cause of the hypercalcemia? It is young lady. It is not old. Primary hyperbara. But primary hyper. Speak with yourself like that. Primary hyperbara. It's common in old age. What else? Tertiary. It is not chronic kidney disease. It could be malignancy. Could be malignancy. It could be what else? Vitamin D drugs overdose. Yes, it could be vitamin D overdose. Yeah, speak with yourself and speak in your mind in 1 minute only. And arrange and reschedules of differential diagnosis. Then to tell the examiner the differential diagnosis like in book, because it will be wrong. If you speak like book, you will so that you can mention for him the first differential diagnosis, it is least or it is not commonest for this patient, because the differential diagnosis is different from one patient to another patient. So that you have to tell the first one the most probably diagnosis. Then you will tell the examiner will ask you what's about your diagnosis and differential diagnosis. Then try with him as you have open mind. Don't to tell him about one diagnosis. Tell him differential diagnosis. And with every differential diagnosis, you have to tell him what with this diagnosis and what against this diagnosis. And if this patient has blood clot, you think is pulmonary embolism, tell him that my first diagnosis, it could be pulmonary embolism. Because this patient has family history of blood clot and he has chest pain and he has shortness of breath. Also, he has past history of blood clot in his legs. So it is with your diagnosis. The examiner will ask you what else. It could be other cause for shortness of breath, like interstitial lung disease, because this patient has joint pain. But I want to confirm my diagnosis by doing this patient X-ray and pulmonary function test. But it is not common in this case. It could be bronchial asthma, but against my diagnosis, there is no diurnal variation of shortness of breath. And also there is no precipitating factor for bronchial asthma. So that you put him the differential diagnosis and what with what else. The examiner will ask you, what is the most diagnosis in this case? Now you can tell him it is pulmonary embolism. But if from the start, if you tell him pulmonary embolism only, no, it's a mistake. I think like patient with fatigue, this patient could chronic fatigue syndrome. But if you tell him chronic fatigue syndrome from the start, okay, he will give you in your differential diagnosis 0 because you didn't give him differential diagnosis. There is an item in the history differential diagnosis. You have to tell him differential diagnosis. You have to tell him like that, especially fatigue case in the history is common. You have to tell him like that. I have a lot of differential diagnosis. I have to exclude all organic cause before I consider it is non-organic cause like chronic fatigue syndrome. In the in one exam, patient presented with fatigue, so that lastly the patient has anemia. After the examiner asks you differential diagnosis, investigations, and the plan of care, all of this in 5 minutes. Again, history, it is very difficult, very easy. If you make for you a plan and a guide, you will get final, the differential diagnosis. But if you put in your mind and you didn't arrange in your mind, you will lose the history case. Some person give history. They did well in the history case, but they failed. Why? Because uh, their differential diagnosis, it is not excellent or not good. They didn't ask about concern. They didn't make a schedule or make a proper plan of care. I think one patient presented with fatigue, and the first item, he told the examiner the patient has chronic fatigue syndrome. He didn't give differential diagnosis for the examiner, so that he gets 0 on differential diagnosis. He lost 4 marks. He didn't ask about concern. He lost another 8 marks. Now he is playing in 12 from 20. Communication with patient, he will lost 4 marks. Why? Because he didn't get differential diagnosis, so that he gave the patient uh, false information. He lost another 4 marks. Now he has 8 marks. Patient welfare, he will lose 2 because the patient is not convinced by his plan of management. So that he failed lastly in the history case. So if you get the differential diagnosis well, you will gain most of the marks. If you didn't do differential diagnosis well, you will lose all marks. Why? Because differential diagnosis depend other items depend on differential diagnosis. Other items like management of patient concern and communication with patient and the plan of management. Most important point in history before I close the discussion about history. The most important point, introduction, main target, and end of discussion. Main target, analysis of complaint. Number 2, system related to the complaint. Number 3, review of other system. Number 4, management of patient concern. Number 4, past history. Then family history, social history. After that, management patient concern. Then end of discussion, summarize, and ask, tell the patient you will admit or no, will not admit him. Then give a plan of care to the patient. After of you finish, you have to rearrange the differential diagnosis and then speak with the examiner. Before you enter the exam room, you will wait outside the exam room for 5 minutes, and you will read the scenario. You have to put differential diagnosis from outside. Don't wait until you enter the room and put differential diagnosis. Put differential diagnosis from outside. Other very important thing, if you try to be fluency, try to speak, don't stop for long time or pause for long time. If you are going to stop, tell the patient, are you with me? I will write some notes in my paper, like that. I hope that this introduction uh, is helpful for others, and I think there is a lot of information for new candidate in this topic now. You have to listen to this information well, and you can write the important note in from this information. And if anyone has a question, he can write a message for me, and I will reply this question. Now, this week, uh, I will give another introduction about communication, and it will be by also voice. And in next week, inshallah, we will start the history and the communication cases. Salam alaikum.